general anesthesia, all of these things, perioperative nausea and vomiting are very common. Temperature changes we worry about a lot because a small group of people has got malignant hyperthermia, anaphylactic reactions because the patient's subjected to lots of different chemicals along the way. More reasons not to take a person to the operating room. It's costly, it's time consuming, it's logistically difficult, and it necessitates aggressive treatment planning, okay? Costly, time consuming, difficult, you can understand. Aggressive treatment planning means if we take a person into the operating room, we're not taking them back a month from now. So we cannot do a restoration that has a mediocre prognosis. So we're very aggressive. We have to try to anticipate probably 5 years or 7 years worth of value. So if we don't think that this tooth is going to be here and be functioning and be asymptomatic 5 years or 7 years from now, we're going to remove it rather than restore it. That's certainly not the way we treatment plan under more conventional situations. Okay? It requires a formal consent, a preoperative history and physical, and lots of labs and diagnostic procedures because of general anesthesia, and these vary a little bit. So back to our friends at the SCDA, how many people use nitrous, okay, how many people use oral sedation, how many people use general anesthesia. These people, I don't know that they really are special care dentists, if that's a thing, because if you never use general anesthesia, if you have a good pipeline where you can send a person for general anesthesia, that's fine, but most patients or most dentists who do special care have to have OR access or have to have someone that they can send the person to for OR access, because you're really not providing a good service if you can treat a person up to the point where they're uncooperative and then you no longer treat them, okay? But you can see that 3/4 of patients who consider themselves to be special care dentists either do some general anesthesia cases or do them frequently. So we talked about preoperative testing. Well, you remember the PTT INR to make sure there are no bleeding difficulties, the HCG pregnancy test. All patients undergoing general anesthesia need to have a pregnancy test if they are women of childbearing age or potentially childbearing age. That woman I would not have guessed was of childbearing age, but she did. She is the oldest woman to give birth. I can't remember how old she was, but she's probably as old as she looks. So you need a negative pregnancy test. Depending on the age and the medical circumstances of the patient, you may or may not need other things. We used to need EKGs on every patient, but in most hospitals now, you don't need one unless there's some known cardiomyopathy or the patient is 40 years old, or sometimes it's 50 years old for females and 40 years old for males. You need a chest film. Again, in some places it's required, and in some places it's only required by age or by history. You need a comprehensive metabolic panel, and you really need to have some idea what these figures mean, because they're going to ask you, their liver enzymes are elevated, you want us to cancel the case, and you have to have an answer to that question, okay? You need a CBC, same thing. How out of bounds is too high or too low to cancel a case? Well, you need to know. So eventually, all these things get done. A history and physical by the primary physician and the chest x-ray and the EKG and all of the labs and everything looks like it's good to go. You have consent, you have an understanding among the family members and the caregivers, and you get to the operating room. So there we are in the operating room, okay? What happens in the operating room? Well, first of all, somehow the anesthesiologist gets the patient to a level of cooperation. And sometimes the patient is cooperative enough that an IV can be started, but they're not cooperative enough to do a sedation, for instance. Sometimes an IV cannot be started, and that's when ketamine, which is an injectable drug, is used. And the patient gets into the operating room, and an IV is started first thing so that they have IV access to administer medications. The patient is moved onto the operating room table, and the patient is induced, and the patient is intubated. Now, if you're lucky, you get a nasal intubation, which is what you request, because if the tube goes from the mouth into the breathing apparatus, it's going to be in your way. It's going to have to be moved by the anesthesiologist every time you switch sides on the case, and it's a real pain in the neck. But sometimes patients have nasal blockages or they're difficult nasal intubation. You work around whatever you have to, but hopefully the patient is intubated nasally, and then x-rays are taken, okay? And this, we make it look easy. Boy, I was fat at one point, okay. But it's not an easy thing to do because remember, the patient can't close his mouth. So you develop techniques and you get good films, and sometimes you tape the tube head, and we have all sorts of tricks of the trade. And then we look at the x-rays, and these days mostly it's done with a NOMAD, but it can also be done with conventional sources of x-ray. And you look at the x-rays and you treatment plan the case. And while that is happening, if you've got a big enough team, someone is scrubbing in and packing the throat. And remember what I said about aspiration pneumonias. It's very important that a throat pack goes in because any secretions, any water from coolant, any tooth debris, any restorative material debris has to be accounted for. It has to be removed so that it doesn't go down the patient's airway, because the patient at this point has a tube down the airway, but when the tube is pulled, if there's debris around it, it's going to go right into the person's trachea. So you can see the nasal tube, you can see that we have prepped and draped the patient, and now we're packing the throat, and that's what it looks like. And now we're going to treat the patient. That's just putting light handles on and things. And we're going to Cavitron the whole mouth, look for caries. We need to do a good periodontal procedure anyway. We're going to clean whatever teeth are there. We're going to prep whatever teeth are there. We're going to restore whatever teeth are there. And doing even simple procedures under these circumstances is less than simple. So, these cases are not easy to do. And then you do whatever oral surgery is needed, and the teeth are extracted last under ideal circumstances because you don't want to do a lot of restorative dentistry in a bloody field. And typically, the oral surgeon will deliver local anesthesia, even though the patient is not feeling things and is not moving, because it allows the anesthesiologist to reduce the level of anesthesia, and it also allows the patient to wake up numb rather than in pain. And then the patient goes in for recovery, and hopefully they recover very quickly, and within a couple of hours they meet the standards for discharge and they will be home. So that's the process. Again, just to recap, general anesthesia and special care is the treatment of last resort, and the risks of anesthesia must be outweighed by the benefits of treatment. And even when it's indicated, it's complicated, it's expensive, it's invasive, it's difficult, but it's also one of the most valuable services you can provide, because there are not a lot of dentists that are doing cases for people that really need to have their care under general anesthesia. So it can be the most satisfying type of dentistry that you can do if you choose to really get yourself seriously involved in special care. Thank you very much.